Hello, everyone. Thank you for
Hello,
joining.
everyone.
You are more than welcome to have your cameras on or off, whatever you're comfortable with. I know a lot of folks know CJ. So, yes, if you want to have your camera on, give a wave. If you want to say hi in the chat, you are welcome to utilize the chat. And before I get started, I am going to do just a couple of quick announcements. As you should have been notified when you joined today's meeting, we do record our continuing education sessions. Um, When the presentation is up, no faces are recorded, and I do edit this and try to keep people's faces out since you all aren't presenting and you aren't part of that process. Um, we do allow for you all to control your microphones, so unless you have a question that is at a specified time in CJ's presentation today, keep your microphones off. We will let you know when questions are ready to be had. Otherwise, again, you can use the chat as much as you desire, um, whether that be questions or additional comments or just to say hi to CJ. Um, for those that don't know me, my name is Teresa Larson. I am a researcher for the Transforming Communities Institute at Utah State. As one of my roles in this position is to help organize and facilitate our continuing education, which is supported by the USU Department of Social Work. If you have any questions about any continuing education, I'm the person that you would need to ask. You can respond to the meeting invite, or you can reach out to our team at tci@usu.edu. Um, as just a quick note, you can change your name here on Zoom as well. We use Zoom to track our attendance, so please make sure that your name matches whatever you will be completing the evaluation with, so we can get you connected to the right certificates and that your attendance is marked. Um, and then before I introduce CJ, I will be providing the Utah State University land acknowledgement. And that is, as a land grant institution, Utah State University campuses and centers reside and operate on the territories of the 8 tribes of Utah, who have been living, working, and residing on this land from time immemorial. These tribes are the Confederated Tribes of the Goshute Indians, Navajo Nation, Ute Indian Tribe, Northwestern Band of Shoshone, Paiute Indian Tribe of Utah, San Juan Southern Paiute, Skull Valley Band of Goshute, and White Mesa Band of the Ute Mountain Ute. We acknowledge these lands carry the stories of these nations and their struggles for survival and identity. We recognize elders, past and present, as peoples who have cared for and continue to care for the land. In offering this land acknowledgement, we affirm Indigenous self-governance history, experiences, and resiliency of the Native people who are still here today. So thank you again for joining us, everyone. I will now introduce CJ, which many of you already know who he is. But CJ Sorensen is a licensed clinical social worker with 17 years of practice experience. He is currently employed with Family Services, living in Frankfurt, Germany. CJ is also an adjunct professor in the social work department at Utah State, where he was previously an associate clinical professor and director of field education. He has served on several nonprofit boards, most recently as executive secretary on the National Board of the Clinical Social Work Association. He has presented locally and nationally on topics including suicide prevention, social work ethics, clinical intervention, and social work education. He earned a BSW from the University of Utah, an MSW from Brigham Young University, and graduated with a DSW from Tulane University last year. CJ enjoys traveling, gardening, podcasts, and spending time with his wife and 3 children. So thank you, CJ. The time is now yours. And if anybody, like I said, has questions, put them in the chat, unless otherwise specified.
All right. Hello, everyone. It's so good to see your faces and your names. And I want to just dispense with the presentation and catch up with everybody as I look at all of you. I miss you. Just very quickly, we're doing well here in Germany, uh, going on adventures and exploring Europe. Um, but we're homesick from time to time, and so it's really great to see you all. Let me go ahead and share my screen. All right, you're seeing the full presentation, I hope.
Yes.
Great. So we're going to talk about the basics of psychopharmacology today. And it's not the funnest topic in the world, but it's stuff that I'm super interested in and very fascinated by. And so I hope that it will be both informative and somewhat enjoyable, even though it's not the most exciting topic in the world. Let's start off with a couple of poll questions. Teresa, would you mind pulling up that first poll with the 2 questions? First one, when it comes to discussing medication, psychopharmacological interventions with my clients, I feel, we're going to use the language of teens today, absolutely cracked, which means like amazing, pretty mid, super awkward, or I rarely discuss it. And if you're done with that one, you can move on to the next one, and then we'll come back to the results. My bias related to medications, psychopharmacological interventions for mental health, is most closely aligned with which of the following statements? My nickname is Candyman or Woman. Get rid of regulation and pass me my Adderall. The FDA is a complete racket in cahoots with Big Pharma in an effort to control the masses through chemical sedation and restraint while they make their billions. I prefer acupuncture, essential oils, and St. John's wort, please. Did someone say weed? You do not need medication, people. You need to go for a 30-minute run every day and eat salmon for dinner with broccoli. Don't forget the broccoli. Medications can be good and medications can be bad, but the best help is found in therapy. And finally, I have no opinion. I am a peacemaker. That's my best attempt at humor, folks. So that might be as as fun as it gets today. All right, so on the first question, it looks like most people, 65% of you, feel just kind of moderate about discussing medications with clients. Only 5% feel super confident and competent, it looks like. And a little over 10%, 12% tend not to discuss it at all. So that's important to be aware of as we have the conversation. And we'll talk about our scope of practice as therapists, social workers, whatever you are. I know that we have a mixed audience here, so I'll try to be mindful of that. Because we can probably be doing more than we currently do. And then in terms of bias here, it looks like most people are on board with the idea that there's some positive things about medications, there's some problematic things about medications, but therapy is really important. We might expect that from an audience of clinicians like we all are. 3% of you are interested in the weed, and close to 20% of you say, nope, not going to engage. Awesome. Okay, now that's kind of humorous, of course, but it's really important to be aware of what our personal opinions are and values are around medication, because there are certainly some intersections with values and medications. We've been steeped in our own kind of family cultures, regional cultures, and other cultures around what medications mean, what you should do when it comes to psychopharmacology and what you shouldn't do. So that's something that I would invite you to just be mindful of as we go through the workshop today. What touches on sort of your own personal values and opinions, and how do you monitor that as you engage with your own clients? Okay, so let's start off with what is our role when it comes to medications and psychopharmacology. And there's actually a lot of different roles that we can take on as clinicians. We can be a physician's assistant. Really, the research says unequivocally that integrated care is best practice. So to be in communication with a prescriber when you're working with a client who is on medications is best care for a client. And in that regard, we can be a physician's assistant. We'll talk more about that. We can also be a consultant using our own experience and expertise to point clients to appropriate resources. We can serve in a counseling role to help a client explore their own values about medications and engage in a decision-making process about starting or discontinuing medications or other interventions that might connect. We are in a very unique position to be monitors. A lot of times people who are prescribed medications, particularly from a psychiatrist, may initially meet with the prescriber 1 or 2 times in succession and then not meet again for 3 months or 6 months. We're often meeting with a client once a week or every couple of weeks. So we have eyes on a client in a way that often a prescriber does not. We often talk more deeply with a client than a prescriber does for a longer period of time. And in that respect, we can really serve in this role as a monitor of how the medication is impacting the client. We can also be an advocate, both in case advocacy and cause advocacy when it comes to psychopharmacology, advocating for the needs of a particular client in certain kinds of settings where they're facing barriers, and certainly looking at the bigger macro kinds of issues. And there are all kinds of intersections, no doubt about it, when it comes to policy and psychopharmacology and the way it impacts people in their real lives. We can also be an educator and provide solid evidence-based information to clients. And of course, we can also be in research roles as well. When it comes to education, what kinds of things are we safe to provide education about? Well, here is a pretty good list. And I'm not going to go through each one of these, but we can feel safe as long as we have, like the Code of Ethics says, the appropriate competency, the training, we have reliable, solid, evidence-based information. We really can provide this education to clients. Now, what is outside of our scope of practice? It is certainly outside of our scope of practice to recommend specific families or specific medications themselves. That is not appropriate for us to do. You know, Zoloft really works for my sister. I think you should try Zoloft. Or Wellbutrin has worked really well for my client. Why don't you try Wellbutrin at this dose? Like, that is not our role. We would always refer them to the prescriber in those kinds of situations. But we can say things like, oftentimes in this situation, a person might be prescribed something from this family of medications, and this is how they work. And these are the risks and benefits of those medications. And you need to have a conversation with your prescriber. We would never tell a client to discontinue a medication. There can be very serious consequences with that. So we want to be very careful about it. So think about what you're already doing in your practice and perhaps how you could enhance the way you're engaging on these topics with your clients. To help us do that, there are some really great resources at our disposal. Here's a list of them here. And I meant actually to pop the slides into the chat. Oh, I see that someone just asked about that. So I'm going to do it now. Give me just a minute. Okay, those are uploading now, and you should have access to them momentarily. The links should work in the PDF document. These are some great lists of different medications and good information about the medications. You can also see there at the bottom the FDA's MedWatch reporting system. This is something that we can use as mental health professionals. You don't have to be a prescriber to use it. So if you have a client who has a serious adverse effect as a result of a medication, you just go on here and together with the client, you can report that to the FDA. It could be very important for them aggregating data to know more about the impacts of a medication on the population. There was once when I had a client who was on a common antidepressant, and one morning he woke up, and as he attempted to get out of bed, he just fell. He fell right out of bed and broke his arm as a result. And it was because as he tried to get out of bed, he just experienced complete numbness and paralysis of his arms. This was shortly after beginning the medication. He had never had an experience like that. He went to the doctor. They couldn't see anything that might have caused that. So it's quite possible that it was a result of the medication and something worth reporting here on this system. Okay, let's talk about models of psychiatric drug action, and then we'll take some time to talk together a bit and distill some of this information we've gone over so far. So for a long time, really for decades, we've used a disease-centered model of psychotropic medications. That is the idea that mental health conditions are a result of disease in the brain. And these psychotropic medications respond to the disease state of the brain and correct the disease state of the brain. So the reason that you take the medication is because you have an illness of the brain. Sometimes we've called that like a chemical imbalance or that type of language. And this is why the medications then help people, because they're correcting a disease process or treating a disease process, similar to insulin treats a diseased pancreas. But in recent years, there's actually been a shift with a lot of researchers and practitioners to what's known as the drug-centered model. And this model suggests, instead of really thinking at all about underlying pathologies or disease of the brain, it just posits that drugs create an altered physical and mental state, and that they do that for anybody who takes them. And sometimes with medications, there is a therapeutic effect as a consequence of taking the medication. It puts you into this altered state, altered mental, emotional, behavioral state, which is beneficial. And the indication to take the medication is simply that that medication provides value. It induces this altered state. So it's a real paradigm shift in the way that people are thinking about psychiatric medications, because despite our very best efforts, we haven't really arrived at very clear or concrete constructs around what mental illness is in terms of its underlying etiology or pathology from a neurobiological or physiological perspective. We've found correlations for sure. We found areas of the brain that seem to be hyperactive or hypoactive, but we haven't found, in most cases, specific gene variations that cause depression, or a certain condition in the brain that results in social anxiety. We're just lacking there. And so they've started to shift to this other perspective. With that being said, what I'd like to do is break out into some breakout rooms and just have you talk amongst yourselves about some of these ideas we've addressed so far. One, and just choose one of these two questions. Unfortunately, we don't have the time to discuss them both. So just choose one in your little group. There will be 5 in a group or so, and we'll take 5 minutes. So what can you do more effectively in your role, whatever that role is, when it comes to clients who are taking medications or considering taking, changing, or discontinuing meds based on the role and scope of practice we talked about? Or you might talk about, what do you see as strengths and limitations of the disease-centered model and the drug-centered model that we just talked about? All right, Teresa, let's go ahead and put them into rooms, and then we'll come back and chat for a moment about thoughts you shared. Awesome. Welcome back, everybody. Let's chat just briefly about a couple questions here. So anybody have a thought you want to share about how you can more effectively engage with clients as it relates to medication?
Parker Buse here. Oh, go for it.
I was just gonna say,
Go ahead, Parker.
like our group kind of discussed that like the way we're gonna support our clients is by attending trainings with knowledge about psychopharmacology. So we were discussing that we just noticed this like gap in our knowledge, and so this is like attending this and talking about is how we're supporting that.
Awesome. And there are others out there. You can go to many hours long trainings on psychopharmacology, which are beneficial. Thank you, Jaylee.
Yeah, we just had kind of 3 different ideas on it. Mine was kind of the similar one, just being more familiar, more comfortable, more informed about medications. It's not necessarily our job to prescribe, but just feeling like we're more understanding. I think that's something we can do. And then a couple of the things that were mentioned were helping clients with compliance. Maybe if you're working in a medical model or field or like area with a physician, just helping, what are the obstacles or barriers that make it difficult for a client to stay on top of their medication, or to things that make it difficult to be compliant with their prescriptions. And then another thing again was just helping weigh the pros and cons of, is this helping? And obviously letting them discuss that with their provider, but just helping them provide a space they can talk about it more freely.
Great. Thank you so much, Parker. Excellent thoughts. And I appreciate the comment in the chat as well. Is it Cash? I hope that I'm pronouncing that correctly. Excellent thought. How about a thought or two about these ideas, the disease-centered model and the drug-centered model? Anybody have a comment or question about that?
In our group, we talked about the mind-body, from a mind-body bridging perspective, that the disease model is more aligned with that theme of brokenness and that something's not right, so it needs to be fixed, versus the drug-centered model, which I prefer, because it goes more to, it may work, it may not. And I also think the follow-up is really important. One thing that I learned in my class was that a lot of times the prescriber is a family physician, or someone who is not trained in the psychology of it. So oftentimes they prescribe these medications and then they just stay on them forever. And they really do lose their effectiveness over time. They're not meant to be on for long periods of time. And so encouraging that consistent follow-up, those every 3 to 6 months or whatever the medication recommends.
Yeah. Psychotropic medications, thank you, Tammy, are the most prescribed kind of group of medications in the United States. And most of those are prescribed by general practitioners or family doctors. And some of them, of course, are very good at that. And some of them are not so good at that and may misdiagnose and therefore misprescribe. And that can have pretty profound impacts on a client and their life, even their identity and sense of self, right? Okay, excellent comments. Let's go ahead and move forward here. And we're going to start to get down into some of the nitty-gritty around the different kinds of psychotropic medications that exist. So when it comes to psychotropic medication, they act almost universally across the board on what is often referred to as the big 3 neurotransmitters. I'm going to have you add 1 and make it the big 4. But these are the big 3 here: serotonin, norepinephrine, and dopamine. Now, it's interesting to note that these neurotransmitters are actually only found in 2% of the synapses in the brain. And they're pretty complex. They interact with each other and with other neurotransmitters. And oftentimes when we talk about them, we talk in pretty simplistic terms. So just know that that's what I'm doing today. And there are lots of really complicated elements to these particular neurotransmitters. Let's go through each one of them quickly. So serotonin, this is a neurotransmitter that has correlations with regulation of mood, with our sleep, with sexual desire and behavior, with memory and learning, with appetite, hunger, and digestion. In fact, 95% of the serotonin receptors in the body are not in the brain. They're in the gut. They're in the digestive tract. And there are medications like anti-nausea medications. For example, if any of you have been prescribed Zofran for nausea, that acts on serotonin. Serotonin also plays a role in constricting blood vessels, vasoconstriction. So migraine medications, you might be familiar with medications like Imitrex for migraine headaches that constrict the blood vessels to stop a headache. That acts on serotonin. Serotonin comes from an amino acid called tryptophan. Where do we hear about tryptophan? It's coming right up.
Thanksgiving.
Thanksgiving, turkey, right? Tryptophan is found in common foods like turkey, salmon, eggs, cheese, pineapple, nuts, seeds. It's broken down, and serotonin is a derivative of tryptophan. Exercise and sunlight seem to help increase the production of serotonin. Many mental health medications target serotonin in some way, shape, or form, and we'll walk through that briefly as we go along here. The next one is norepinephrine, or noradrenaline. So norepinephrine is both a neurotransmitter and a hormone. When it's in the nervous system, it's a neurotransmitter. When it's in the adrenal system, it's a hormone, and it's called noradrenaline. It's actually a derivative of dopamine, which we'll talk about in a minute. And it plays an important role in alertness, arousal, attention, and the sleep-wake cycle. It's also can sort of be naturally consumed through foods like different kinds of meat, fish, nuts, eggs, and cheese. Exercise, sleep, and simple pleasures seem to activate and increase norepinephrine in the brain and body. And then finally, we have dopamine. Sometimes it's called the pleasure, pain, and rage chemical. It's also both a neurotransmitter and a hormone. What scientists have found recently is that it's not so much dopamine that causes a sense of euphoria in our reward systems, but dopamine seems to reinforce the memory and cues around the pleasure that we experience, that then encourages us to seek out that experience again, or to be triggered with memories of that pleasure when we're in certain kinds of contexts or faced with certain kinds of stimuli. Dopamine is also found in common foods like chicken, almonds, avocado, bananas, chocolate, legumes, leafy greens, foods that are high in magnesium that is broken down further into dopamine. Exercise, meditation, playing with an animal, and being in nature are all things that help to raise levels of dopamine. So those are the big three: serotonin, norepinephrine, and dopamine. And then the one that I'm going to add is called GABA. That's an acronym. It stands for gamma aminobutyric acid. Gamma aminobutyric acid, or GABA. It's a general neurotransmitter that's involved in a lot of neurotransmission, like 75 to 90% of all neurotransmissions, and it plays a role to inhibit neurotransmission. So we might say that GABA is the brakes of the brain. Remember that as we go along here. So the big four. Now let's talk about the families or categories of psychotropic medications. For a long time, there were 5, but now with recent development, we really have to consider 6 with the rising use of psychedelics. So we have antidepressants, mood stabilizers, anxiolytics or anti-anxieties, psychostimulants, antipsychotics, and psychedelics. If you're like me, it might help to think of some mnemonic devices to remember those categories. So you might do an acronym, and it could be PAPAMA, PAPAMA, or accessing medication aids patients and pets. I don't know if Brian Dubray is on the call here today, but he tells a very funny story about his parrot who had to be prescribed Prozac. Yes, our pets and animals are also prescribed some of these medications. Okay. We are going to jump back into groups. And Teresa, let's just do 4 minutes if we could. And you might choose one of these 3 things. Come up with your own mnemonic device to remember the big 3+1 neurotransmitters, or teach back to each other what they are to try and recall them and what their basic roles or functions are. Or you might create your own strategy to remember those 6 categories of psychotropic medications. My goal here is to just help us come up out of the monotony every once in a while, and talk with each other and try and internalize the information a little bit more, so that I'm just not talking straight here for an hour and a half. All right, let's go ahead and get into those groups for 4 minutes. Welcome back, everybody. Did anybody come up with a fun way to remember this information? Let's hear it.
Come on, Jeremy, share yours.
Well, he
That's what
said
I was
fun.
gonna say.
Mine's not fun, but I think it gets the job done. I
Yeah,
did
fun
great.
or effective.
Yeah, great drugs stimulate neurotransmitters for the big
Nice.
3+1.
I like it. Great drugs stimulate neurotransmitters. Is that what it was?
Yeah.
Nice. Very good. Anybody else?
I know Shannon had one, and if she doesn't want to, I can read it and give her the credit. She said, always make a point to access pills for AMAPAP.
For AMAPAP or PAPAMA, however you want to do that. Very good. Thanks for sharing, Devin. All right, let's move into these specific categories. We'll talk about each one and hopefully equip you with a little bit more information about them. So we'll start with antidepressants. Well, actually, before we go there, let's pause and just see if there are questions that are kind of burning about the big 3+1 or the categories of psychotropic meds.
I have a question. Hi, CJ.
Hello.
Hello. So that's really interesting about dopamine, how it's like when you eat a candy bar, you think like, oh, I've got all this dopamine being released, but you're saying that it's more that the dopamine helps you remember the candy bar, and then next time you see something that looks like a candy bar, it will release chemicals to say, hey, remember that felt good, you know, that pleasure. Right? Is that right?
Right. Yeah, that's the most recent theory. Whereas before, there was the idea that, of course, there's the pleasure, you know, in our taste of the candy bar, but that the real pleasure of eating occurred in the reward center, the pleasure center of the brain, with that increase in dopamine. Now the theory is that dopamine maybe isn't causing that euphoria, but dopamine is imprinting and reinforcing the pleasure of that experience so that you remember it and are cued to it in the future. That's right.
Thanks.
Other questions? Thanks for putting that in the chat, Devin. Okay, we will go ahead and move forward then. So first up, antidepressants. There are a number of subcategories of antidepressants. We'll run through them quickly, but focus mostly on the first line treatment, the most common ones that are used. Obviously, the goal of antidepressants is to treat an acute depressive episode, to prevent relapse if someone maintains on the medication, and to heighten someone's functioning even in the midst of a depressive episode. The prognosis is fairly good, up to 70% improvement rate in clinical trials. Now, that's not complete resolution necessarily for some people, but some level of improvement up to 70% of people. However, it's really important to note this caveat, that antidepressants seem to be most effective for moderate to severe depression and seem to be no better than placebo for mild to moderate depression. Somewhere between 29 and 46% of people may not respond to antidepressants. And the reason why that's such a huge variation is just because different studies find different things. And if they don't respond to the first one, they're about half the chance that they'll respond to a second. In general, these meds take anywhere from 4 to 8 weeks to reach their full effect. They are not an immediate action on the depression. It takes time to build up the serotonin in the system of the brain. And they should be maintained for at least 16 to 20 weeks, though most people would say more like 1 year, maintained for at least 1 year. And these medications should not be discontinued abruptly. There can be some real negative effects if you go off of an antidepressant abruptly. That is not pleasant at all. Okay, so there are some old antidepressants. They're called tricyclics. These were the first to come on board back in the 60s. We're not going to spend a lot of time on these. They're not used anymore because there was really high potential for side effects and high toxicity. So you can imagine that it's really not the best idea to give someone who is depressed and suicidal medications that, if used to overdose, would be lethal. So these have mostly fallen out of favor. They are still used sometimes. You see them very rarely. Then we have MAOIs, monoamine oxidase inhibitors. Again, you don't see these used very often, but they are out there. They are older antidepressants that were used before SSRIs and SNRIs. They also have pretty high toxicity, high potential for side effects and interactions with other drugs. So you might recall, if you read the medicine bottle on cough syrup or Tylenol or something like that, it will say, you know, check with your doctor if you're using an MAOI, because there are lots of interactions. The first line treatment for depression is SSRIs and SNRIs. Now, probably most of you, if not all of you, are pretty familiar with these medications. What they do is block the reuptake of serotonin. So after a neuron fires and it goes into that junction or synaptic gap, then it is absorbed into the receiving cell, but there's some left over. And what happens after it's left over, after cell firing, is that it's taken back up into the sending cell. And these medications block that action so that the serotonin lingers in that synaptic gap. And then the brain builds more receptors on the receiving cell to accommodate more flow of serotonin. This is believed to be the action that ultimately improves the mood by raising the overall levels of flow of serotonin through the brain. And that's why it takes time for it to reach its full effect, because it takes time for the brain to build those new receptors to accommodate the increase of serotonin in the synaptic gap. There tend to be mild to moderate side effects with this medication, these medications, that generally resolve within a week or two. The most common side effects are upset stomach, headaches, and impacts on sleep. There's also very common sexual side effects, so decreased libido and difficulty or inability achieving sexual arousal and climax. There's a black box warning for these medications for teens and young adults for an increased risk of suicidality. We should also monitor for serotonin syndrome. This is a dangerous condition caused by too much serotonin in the body. How can this happen? It might happen if someone is taking an antidepressant. And remember, before I mentioned that some headache medications act on serotonin. Some medications for nausea act on serotonin. And there's lots of natural supplements that act on serotonin too, like St. John's wort or SAM-E. So if someone's taking these medications in combination or taking the medications with a natural supplement, they could potentially be overdosing on serotonin, essentially, and experience serotonin syndrome, which is a fever, high blood pressure, flu-like symptoms, rapid heartbeat, a very unpleasant condition. On the left-hand side, you see some examples. This is not an exhaustive list, by the way, but the most common examples of SSRIs with their brand name on the left and their generic name in parentheses. Then we have SNRIs, very similar to SSRIs, but they also act on norepinephrine to block the reuptake. Very similar in terms of side effect profile. There's also a black box warning on these medications. Now, fortunately, in recent years, there's something called precision prescribing. One of the most common that's used is called GeneSight. This is a genetic test, actually, that's done at a doctor's office. Some use saliva, some do a blood draw that allows the prescriber to get results that tell the prescriber which of these medications are most likely to interact effectively or metabolize effectively for that particular person. And usually they do sort of like, these are green light, these are probably no-goes or red light, and these ones you might want to use with some caution. We're getting better at the technology to be able to precisely prescribe instead of just the trial and error that we've had to do in the past. There are also some atypical antidepressants that are commonly used. The list you see here. You maybe have heard of Remeron as one that's also used a lot for sleep. Wellbutrin is very common. And these are often used in combination with an SSRI or an SNRI. So for example, someone might be prescribed Prozac and Wellbutrin. The Prozac acts on the serotonin, the Wellbutrin acts on dopamine and norepinephrine. Any questions about antidepressants? Okay.
I have a quick question. Sorry.
Please.
At the beginning, the first slide that you put up about antidepressants indicated that they are typically meant for acute depressive episodes. But I'm also hearing that it takes a long time for them to kind of work, and it also takes weeks and months after that they're recommended to be on it. I'm just curious about that wording of it being an acute approach.
Great. Yeah, thank you for the clarifying question. So what we mean is that one of the functions or goals of antidepressants is to resolve an acute episode, but they're not intended for acute treatment. They're actually intended for longer term treatment, again, at least 1 year. Some people, of course, remain on antidepressants for the duration of their life. But the immediate goal, of course, is to get them up out of that depressive episode. So that's what we mean by treat the acute episode, get them out of the depressive state, and then maintain so that there's not relapses of that depressive state. Does that clarify?
Yes, that's really helpful. Thank you.
CJ,
Okay,
this might be covered later. Sorry, there's a question in the chat about the impact of a missed dose, but you might be covering that later.
Okay. Yeah, so every medication is going to vary when it comes to missed doses. And it's good for us to really encourage our clients to be consistent and then to talk to their prescriber about what they should do if they miss a dose, because every medication is a little bit different. Now, in generally speaking, most of the time for an antidepressant like an SSRI or an SNRI, it's not a huge deal if a dose is missed and you just pick up the next day. If you forgot it in the morning, for example, it's not a big deal to take it at lunchtime or in the evening, because again, the half-life is very long. It doesn't have like this immediate effect. But that's a really great conversation to encourage our clients to have with a prescriber when they're first prescribed the medication or when they go in for a follow-up. You know, if I happen to miss a dose, what should I do? Okay, let's talk mood stabilizers. Mood stabilizers are prescribed typically for bipolar disorder in any of its varieties. So bipolar 1 or bipolar 2, as well as cyclothymic disorder. So Goals are to stabilize the acute mood episode, to prevent relapse, reduce the sub-threshold symptoms, so the symptoms that someone might have even when they're not in a manic episode or a depressive episode, and decrease suicide risk. You may know that bipolar disorder has one of the highest risks of suicide of all psychiatric conditions. The prognosis is fairly good, 40 to 65% improvement rate across various types of the condition. Now, you might think that doesn't seem very good to me, but actually, when we're talking about mental health conditions, those rates of improvement are quite good, even with therapy, I might add. So in controlled trials of therapy, if you get a positive response rate of 40 to 65%, that's considered quite good. These medications start working in 7 to 14 days, so 1 to 2 weeks, but longer for total resolve. Oftentimes, they're used over many years, again, to reduce the risk of cycling frequency. These medications also should not be discontinued abruptly. Now, there are kind of two subcategories within the mood stabilizers. There's lithium, which is the gold standard for bipolar 1 disorder that's characterized by mania especially. Lithium is a naturally occurring salt. It's on the periodic table of elements, if you remember that from your chemistry days. It works by affecting the chemicals around and within the neuron to decrease the amount of firing that's happening. Because a manic brain is an overactive brain. It's a brain that's firing like crazy and creating a manic state. Unfortunately, there is high toxicity with lithium, so you have to be very careful, and blood levels have to be monitored over time to make sure that you're at the therapeutic range of lithium. Otherwise, there could be some negative consequences. There are some potential serious side and adverse effects. Weight gain, very significant weight gain is one of those. And there are also some significant drug and dietary interactions. Lithium is not used whenever possible. Often with bipolar 1, it ends up being the best choice, but anticonvulsants are also commonly used, especially for bipolar 2. So anticonvulsants are anti-seizure medications. You may know that those are both, they're used for that dual purpose, anti-seizure and for bipolar disorder. There's a list of the common names there. These medications work by acting on GABA. Remember, we learned before that GABA is the brake of the brain. So it inhibits neurotransmission. The brain is firing like crazy. Increasing GABA slows that down and stabilizes the mood. So these mood stabilizers tend to target the hypomania and the mania better than they do the depression. But Lamictal does have good evidence of also being helpful for depression. There's a warning on these drugs for suicidality, but it is not a black box warning like for SSRIs and SNRIs. Okay, let's take a pause here and just get a couple of comments. I'm mindful of time here. What benefits have you seen in clients taking antidepressants or mood stabilizers? What side or adverse effects have you seen? Let's just start there. And a comment or two?
I have an interesting one that I would like to share.
Yeah, please.
So I work at a mental health facility, and I have a client of mine that it's been really interesting to see him get on some of these antidepressants, and he self-reports to me that In his life, he has not been used to having any sort of level of serotonin in his body. And so he's kind of processed everything very logically, almost robotic, not with a lot of emotion. And so now that his body has more serotonin in it, he's had to kind of rethink how he views the world and how he views other people, and how it's almost how it's almost been stressful to him. And so he's had kind of a difficulty with adjusting to that. He's adjusting well, but he said at first it was kind of freaking him out because he had to rethink how he thinks about everything now that he has some serotonin and has some emotion.
Yeah, it's a really fascinating response, and it's an understandable response. And often we don't think about the impacts on a person's sense of self when they take medications, and they have altered or new experiences that they hadn't really had before. And it can be a difficult transition for them to understand it and respond to it in ways that feel helpful to them. And in this case, it sounds like there was a positive impact of the medication, but nevertheless, it was hard for this individual to figure out what to do with that and how to work with it. Thank you for sharing it. I appreciate it. I've seen in the chat too, a lot of people talking about numbness. People will talk about a lack of emotion, this sort of lexithymia. And that's a very common reaction to these kinds of medications. And you can imagine that that must be very frustrating. And it's a place where we can intervene in that counselor consultant role to help a client process through the impacts of the medication in that way. Parker asks, I'd be curious about how many people take medication without therapy. Yeah, there's a lot. The evidence is pretty clear that there are a lot of people on medications, psychotropic medications in particular, who do not engage in therapy, some never having engaged in therapy. So that's a really interesting conversation to have. Yeah, Trisha, thank you for that comment as well. That's another very common experience for people in this dilemma. You know, do I live with the side effects of the medication and the benefits? So I don't have as much depression, but I have no sex drive. Or do I have a sex drive with depression? These are very complicated dilemmas for people. And we're in a unique position to be able to help talk through them.
I was just
And of
going to
course,
add a positive, CJ, but you can keep going. Sorry.
No, please add a positive.
I was just going to say I've seen clients who, like, oftentimes those who find the one that works well will report saying like they didn't realize how hard life was for them and like how good it could be, how much easier it can be to get out of bed, how much easier it is for them to actually remember the coping strategies or to use them. A lot of clients, I'm sure y'all have heard it too, even just from friends and family who are like, you regular people just feel this way all the time. Like that can be a really positive experience. And I found that it can help a lot to boost their confidence and motivation to feel like they can take care of themselves and like actually make progress.
Yes, for sure. We've probably all had experiences where, without hyperbole, people experience the benefits of medication as miraculous, as completely life-changing and life-altering in a positive way. So it's a complicated picture, isn't it? Okay, let's go to anxiolytics or anti-anxiety medications. These medications can be helpful in treating panic. So treating panic and then managing symptoms to engage in psychosocial interventions for anxiety. Very high success rates. Anxiety conditions are quite treatable. We have a few subcategories here. We'll talk about benzodiazepines are one, and they have immediate but short-term effect. Others are actually SSRIs and SNRIs, which we've already talked about. They are the first-line treatment for anxiety disorders of all types. They should be, the research is very clear that they should be paired with psychosocial interventions to go along with this conversation we're having about the importance of therapy. So again, we've talked about these medications already. You can see here some of the SSRIs that are approved for different anxiety conditions, PTSD, OCD, panic, and some SNRIs that are encouraged for social anxiety and generalized anxiety. Now, benzodiazepines are somewhat controversial. Here's a list of those medications. These are meds like Xanax and Ativan. They act on GABA as well. They are physiological depressants. They have minor side effects. The biggest one is sleepiness. There's a high potential for abuse and dependency with benzos, and something called coping atrophy. What that means is that my capacity to cope with anxiety actually lessens over time when I'm dependent on benzos. Because when I'm anxious, I immediately take a medication that calms the nervous system, and my capacity to tolerate that anxiety then lessens over time. And so then I become more anxious about ordinary things with less capacity to cope with it. So the recommendation now is that benzos really should be used as a last resort, especially for panic disorder and very short term and not in an ongoing way. Abrupt cessation of benzos can be dangerous, especially if someone is dependent on them. And when combined with other depressants, it's a deadly combination, sometimes called the Hollywood cocktail, when people combine alcohol, benzos, and hypnotic drugs like Ambien or Lunesta. That can lead to overdose and death. So we want to be careful with benzos. There are also some atypical anti-anxiety meds like Buspar. You may have clients who are on Buspar, oftentimes in combination with an SSRI or an SNRI. And then more commonly, you're also seeing some of these actually blood pressure medications that are used to treat anxiety called clonidine and guanfacine. These meds are also used when people are detoxing from alcohol. Okay, I'm going to move ahead to stimulants, and then after stimulants, we'll pause for a moment for any questions. I'm just sort of monitoring the time here. So stimulants are the next category, psychostimulants. They help manage behavioral symptoms to enhance functioning and improve focus and attention. They're quite effective in their impact. They have an immediate and relatively short-term effect, but they can be discontinued fairly easily. So there is a high potential for abuse or problematic use of psychostimulants, but not in the same kind of way that creates dependence like benzodiazepines. There are short-acting and long-acting stimulants. So Ritalin and Adderall are short-acting, but they both have extended release versions that are longer acting. These work by blocking dopamine transporters. So chemicals that actually take dopamine away, they block those so the dopamine stays and it stimulates the brain. So a hyperactive or unfocused brain is actually an unstimulated brain. That's why folks with ADHD have trouble in the classroom, but they can sit in front of a video game for hours, right? Because they're stimulated. So these meds stimulate the brain and actually then create the capacity for maintaining attention and focus. There are potential side effects, some cases even of psychosis. Remember that, notice the generic name of Adderall is amphetamine. This is essentially legal speed in pill form, right? So there are potential for adverse effects, including psychosis in some individuals. Okay, let's pause there. Any questions or comments about anti-anxieties, stimulants?
CJ, I posted one in the chat and we haven't gotten to it, but maybe you will. When I worked at the psych hospital, a lot of times they would prescribe Abilify in addition to other medications because Abilify makes them kick in quicker. Do you know anything about that and what categories they would use Abilify in conjunction with? Thanks.
Yes, great question. That's our next category, so we'll get right to it. Any other questions? Okay, these can just be food for thought for you that you see on the slide here, just because I think they're really fascinating questions. I was very interested to see some news this week that 25% of American adults believe they have ADHD. That's a relevant for us question for us to kind of think through and the potential implications of that. Okay, so the next category is antipsychotics or neuroleptics, they're sometimes called. The goal with these medications is to eliminate the positive symptoms. What do we mean by positive symptoms? We mean delusions, hallucinations, and unorganized speech and behavior. So the presence of something that isn't supposed to be there, that's positive symptoms. It doesn't mean good in this sense, right? Reduce agitation, improve cognitive processes, and minimize the negative symptoms. Negative symptoms are the absence of something that should be there. So poverty of speech, difficulty in social relationships, negative affect, and emotionality. The prognosis, 45 to 50% will just be partial responders, so they benefit some, but don't experience complete resolution. These drugs have immediate sedative effects, and they're often used for that, to sedate someone. So back to the question that was asked about Abilify. Abilify is an antipsychotic. It's what's called second generation antipsychotic. So these medications that first came online back in the 50s were considered miracle cure. They would solve mental illness forever. They act by blocking dopamine, but they had really significant side and adverse effects. The biggest of them is these Parkinsonian-like symptoms, because too much dopamine is correlated with psychosis. Too little dopamine is correlated with Parkinson's disease. So people take these medications when they're psychotic, and it blocks the dopamine, and then you see them and they have tremors, or they have tardive dyskinesia, which is involuntary movements of the face and jaws. They grimace, they blink a lot. These are very common side effects of antipsychotic medications. So the second generation are a little bit more effective with less of those negative adverse effects. So they're used more commonly now. And because they have that immediate sedative effect and that immediate effect of managing problematic behavior, they'll often be used, especially like if someone is manic or their behavior is troubling and disruptive. They will use an antipsychotic as the other medications get on board. Sometimes that will be true with depression as well. They'll use an antipsychotic because some of them actually have properties that act on serotonin as well. So they use it as an adjunct as those other medications take time to build up efficacy. Hopefully that answers that question. Okay, other questions related to stimulants, antipsychotics, and we'll wrap up with psychedelics, which I'm sure everybody is eager to hear about.
I have a question. Sorry, I don't know how to get my hand to raise.
Please go ahead.
So I read an article in the New York Times just fairly recently about a new antipsychotic drug that reacts in a different way. It says it doesn't react by it influences dopamine levels, but does it indirectly by changing levels of another neurotransmitter, acetylcholine. And it's called Cobenfy, Cobenfy. Have you heard of that at all, or?
I haven't. I'm sorry, I'm not familiar with it.
No, that's okay. I just thought it was so interesting. It's supposed to be for schizophrenia, and it's supposed to kind of avoid all of the yucky side effects that you were talking about. So I thought that was interesting.
Yeah, there are people working on better alternatives because folks who experience psychosis like schizophrenia, their lifespan is reduced on average by 15 years. And some of that is because of risky behaviors or the co-occurrence of substance use. But some of that is because these medications are very hard on the body. They're not good to the liver and the kidneys. And it reduces lifespan. You can really empathize with people who need to be on these medications to control their symptoms, but also experience really difficult side and adverse effects as a result of the medications. Okay, let's move ahead to psychedelics because we're short on time here. And we'll see what kind of time we have remaining for questions, and I'm happy to stick around for a minute if there are additional questions. So of course, psychedelics are a pretty recent, relatively recent phenomenon in terms of formalizing the use of psychedelics for the treatment of mental health conditions. As you all know, they've been used for many centuries by different cultures for various reasons. So let's talk about the evidence. I'm just going to focus on 3 that fall into this category. We'll talk about cannabis, ketamine, and psilocybin. Now, when it comes to medications, it's super important that we are looking at the best evidence which comes from systematic reviews using meta-analysis and over time. Longitudinal studies are best as those can emerge, and double-blind randomized controlled trials. Those are going to be the best in terms of not introducing bias. And it looks at a whole bunch of studies together, right? It combines studies over many years to give us the evidence. So that's what we'll talk about with these 3 different types of psychedelics. First, cannabis. We know that cannabis is effective for treating some chronic pain conditions. But the evidence is increasingly clear that cannabis has very limited, if any at all, effectiveness for treating psychiatric disorders. In fact, it seems to increase the risk of psychiatric symptoms, including psychosis. And the more frequent the use, the greater the risk becomes for the onset of psychiatric symptoms, including psychosis, or the worsening of those symptoms. Let's jump to ketamine. So ketamine is a dissociative anesthetic with hallucinogenic properties. It's been approved for a long time as a Schedule III drug to be used in anesthesia, usually short-term anesthesia. And then S-ketamine, which is just a variation of the ketamine molecule, in a drug called Spravato, is a nasal spray that's used for treatment-resistant depression. That's approved by the FDA. There's a lot of attention and focus on ketamine being used for various mental health conditions. Last year, the FDA gave a warning about compounded ketamine. Compounded ketamine is when you take ketamine or another compound and you combine, mix, or alter it in some way, and then put it in a form that people can use. So this is what was determined to cause Matthew Perry's death. Compounded ketamine on top of ketamine treatments. So there is the potential for serious and adverse effects of compounded drugs, and ketamine has not yet been approved by the FDA for the treatment of psychiatric disorders. Now, with that said, there is promising evidence of ketamine's effectiveness to treat different mental health conditions. Lots of anecdotal evidence, and some really promising studies as well that suggest this could be very helpful for people. One systematic review says robust, rapid, and transient benefits. With that said, more needs to be done to study ketamine. We need longitudinal studies. We need larger, more robust, randomized controlled trials that are double-blind studies. And lastly, psilocybin. So this is the active agent in mushrooms. It's a Schedule I drug. So that means it's illegal and is considered by the government anyway to have no medical use. But sometimes the FDA approves Schedule I drugs with what they call breakthrough status so that people can research these drugs. And the preliminary evidence with psilocybin also is very promising with limitations. So small studies over time, lots of them are building. And we don't want to criticize small studies. They're very important and they help build evidence over time. But when it comes to the health and safety of people, it's really important that we have strong, robust studies over time that are double-blind, randomized, controlled trials that can be generalized. So very promising possibilities with psilocybin to reduce depression, anxiety, and substance abuse, as well as help with PTSD. With all of these psychedelics, it's really important that there be therapeutic integration alongside the treatment with the substance. And there's controversy and debate in the field right now about the ethics of this. We're figuring it out, right? We're just emerging therapies here, and we're trying to figure out what is best. But most experts recommend that it not just be the ingestion or the intake of the medication, but that there's also some sort of psychotherapeutic integration. Folks experience on these medications usually an altered mental state that allows them to rework perceptions. And this can be very positive, of course, but people can also have very bad experiences with that. Maybe you've had clients who have had that. So it's important that there be this support and monitoring and integration as part of the process of healing when it comes to psychedelics. All right, I think I took us right to the limit there. I'm happy to stick around with folks for any questions, but I'll turn it back over to Teresa with any last comments she needs to make.
Yes, thank you, CJ. I just have a couple, and then folks can ask CJ questions afterward. I put the link to our evaluation in the chat. It will also be emailed to you, so you don't have to do it right now. but that does have to be completed in order to receive your continuing education certificate. So please complete that evaluation. Once that's done, you can expect to receive a certificate in about 2 weeks. If you haven't received it by end of October, feel free to reach out, but hopefully they'll come sooner than that. I will share here on my screen the social media codes for the Transforming Communities Institute and USU Social Work. If you're interested in other trainings, events, projects that the Transforming Communities Institute is working on, you can follow us on social media. The recording of this session will be put onto the TCI YouTube channel in a week or so. So that's the one if you want to review what was taught today, check out our YouTube channel. And then USU Social Work also has their own events and exciting things going on in the department, so follow them.